Good morning. Happy Tuesday, everyone. Welcome to another edition of Clinical Tuesdays on the PT on Ice Daily Show. My name is Jason London. I'm a lead clinical faculty with Rehabilitation of the Injured Runner and Rehabilitation of the Injured Cyclist courses. And this is my first time on Clinical Tuesdays. I'm usually over on Fitness Fridays. So for those of you listening for the first time, welcome and hello. So today what I wanted to talk about and jump over onto Tuesday is Maigne Syndrome. And Maigne Syndrome is basically a syndrome of where a patient is having hip pain that really the source is at the spine, specifically the thoracolumbar junction. Maigne Syndrome was first described by a French physiatrist of the name of Robert Maigne, M-A-I-G-N-E, in 1972, and has been shown to be hip-related pain or hip pain that's coming from the thoracolumbar junction, from the dorsal ramus of the facet joints of the TL junction, namely L1, L2. And so to start you off today, we're going to talk about Maigne Syndrome and really kind of spinal mediated extremity pain. So I think we as PTs, perhaps better than most other healthcare professionals, know that we can have extremity pain that has a spinal origin to it. We've probably all had a referral of a patient with shoulder pain or shoulder impingement. Seems to usually be from internal medicine. That really is more of a cervical radiculopathy where they're the cause of their shoulder pain. And we've probably had numerous patients with hip pain where it's the real origin of the pain is from the spine. And if you haven't been looking at the spine for patients who are complaining of hip pain, hopefully you will start to after today and just be kind of thinking about that throughout the rest of the week with your caseload. So the EXPO study was a study done by McKenzie group or McKenzie trained therapists and published in the Journal of Manual Therapy this past year, and really kind of highlights the point and the prevalence of spinal mediated extremity pain that's not necessarily radicular in nature. And so what they found was of all the joints that they looked at, so ankle, knee, hip, wrist, elbow, shoulder, the hip had the highest prevalence of spinal-mediated pain. So where there really wasn't, the pain-generating structure wasn't necessarily in the hip, but it was more from the spine, with 72% of cases in their study of hip pain actually being from the spine. So, I think, and then I'm going to illustrate a case study here of a patient with Maigne Syndrome. So, if you haven't been looking at the spine, particularly the TL junction in your patients with hip pain, hopefully you will after today. So I had a patient a few weeks ago who's a 43-year-old runner and cyclist who came in with complaints of posterior lateral and anterior groin pain, posterior lateral hip pain, anterior groin pain for the past 2 years. Symptoms originally came on following a 10-mile trail run and then getting in his car and driving back home, which was a 6-hour drive. And then he's had hip pain ever since. And his pain is exacerbated with sitting, with cycling, following running any distance, or running 10 miles or more. He starts to get pain during his run. And he also had recently been to the orthopedic surgeon and had x-rays of his hip, which showed femoral acetabular impingement and likely suspicious of a labral tear. So he was scheduled for an MRI the following week. And so, on face value, looking at his history, kind of thinking, yeah, probably could be acetabular labral tear causing his pain. And so, that was my number one hypothesis. But there were a couple things that made me pause and thinking that, well, maybe it could be of something coming from somewhere else too. Number one was pain. Kind of the worst provoking activity was cycling, and number two was just the pain with sitting for really any length of time, and the pain with running too, which certainly could have been hip mediated, but just the nature that he didn't have any hip pain during his run, and then got in the car and then drove 6 hours. And upon further questioning, the run that he'd gone on was an off-camber trail. So basically, one foot was kind of always having to reach a little bit further. So he was probably having a kind of an asymmetrical posture of his trunk and of his hip, for that matter, while running. And he didn't have pain while he was running. It was after that car ride. So on physical exam, he did have a positive Fader sign. Also had a positive Faber with kind of groin pain and limited range of motion. However, his strength was really good, both for hip abduction, hip extension, kind of the internal external rotation, as well as he could perform a single leg squat with really good form and without pain. Looking at, and then he was also limited with hip flexion range of motion too, with that would reproduce his anterior groin pain. So also looked at active spinal range of motion, which was essentially normal except a little bit limited in side bending, which did recreate some of his posterior lateral hip pain. Then dug a little bit deeper and did some really good central PAs to the lower thoracic and also lumbar spine, which didn't really generate too much, but then did unilateral PAs. And on that side that he was having hip pain, which was his left side, he did have noticeable stiffness at L1, L2, and with really getting in there and getting to end range with that PA, that did reproduce some of his lateral hip pain. So hung out there for a few moments and did some PAs as a treatment, unilateral, followed by some central PAs, and then retested things. And he actually had full hip flexion range of motion without pain after that, and his Faber sign was negative. So going along those lines, again, having good hip strength, really good form with a single leg squat, which was just kind of a quick screen for mechanics for me, especially for runners. Said, okay, we're going to treat this more as a back related issue than a hip related issue, and gave him a home program of basically just working on his rotation and side bending, and then have seen him for subsequent visits for manual therapy, which has resulted in greater than 50% reduction of his symptoms. He has been able to go back to running shorter distances without hip pain following, is able to sit for longer periods of time without hip pain. And then cycling was still somewhat painful for him. And interestingly for him, mountain biking is not painful at all, but cycling, particularly on his trainer, was painful. So thought process here as well, maybe, with a more aggressive position on a road bike, that's causing more hip flexion. It's certainly causing more lumbar flexion. And so, talked about seat height with him, and is actually a kind of a stationary trainer, so it's not like he could bring the bike in. Had him bring his cleats in and adjusted his stance width to widen his stance, as well as the amount of rotation in the cleats, and now he's able to cycle for a much longer period of time without hip pain, as well as by having him get into a more upright position with where the bars are. And so we're still actually seeing him. He's not completely done with treatment. We're starting to do a little bit more hip-focused things. He did have an MRI showing an acetabular tear. However, things aren't quite lining up with that being his pain generator, where it really does seem to be more of this Maigne syndrome with him. And so, thinking about those patients that you're seeing today or later in the week, if you're having a patient with hip pain, even if they have a diagnosis of femoroacetabular impingement or a labral tear, really make sure that you are doing a good thorough screen of the TL junction, mainly with looking at rotation, active rotation with overpressure, active side bending with overpressure, and then really getting in there and doing some good PAs and unilateral PAs and seeing if you can reproduce any of their pain or change any of their clinical asterisk signs. And so there also is a case study that had been case series that had been published in JSPT last August, I believe, but not quite the patient population that I just discussed, with a very active 40-plus-year-old runner cyclist. That case series is kind of more of a sedentary population in their above the age of 65. So any questions you have, shoot them down in the comments, or you can email me is a great way too. And hopefully we'll see you here at the beginning of April at the sampler. Otherwise, I'll be teaching the rehabilitation of the injured cyclist course. I think it's the first week of May in Minneapolis. Have a great day, everyone.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.